Hi, Don here. Welcome to Podiatry Practice Mastery. We're helping you bring your practice to the $1 million mark and beyond. I want to make kind of an uneasy confession. I made my first Facebook ad today. And what I mean about uneasy is because it wasn't an easy process. I've had someone doing them for me. They were basically doing one for warts. I had this wart page and I was doing Facebook ads. I was spending, I think it was ending up, they spent like $10 a day on these things, but they really didn't bring many patients in. Like I didn't see tons of patients get in, so I turned it off. And I have been, my favorite guy to listen to lately is Alex Hormozi, just my favorite podcast, I shouldn't say guy. But he talks about trying to take the best YouTube short and then tack an ad on the back end of it. And so that's what I did. I took my best YouTube short and I put an ad on it. But it was kind of a painful process to figure that out. Now mind you, I did it after surgery. So I had surgery in the morning. I had a neuroma removal. Then I had some time, and I was thinking, well, what's the best thing and like the biggest pain that I can work on that I don't want to work on, but I probably have to learn how to do. So I did this. Started out easy at $5 a day, and we'll kind of see what it brings in. It's going to be going to my urgent care page. So my main focus is filling up this new doctor. So there are slots every day for this new doctor, so trying to fill up this urgent care page. So this is what I've done, and it's not a comfortable process. Like you have to edit the video, you have to do like another 3 seconds on the end, so I had to move it over to CapCut and then put a little end screen on it. It looks horrible. If you want to see it, shoot me an email. Happy to send you the links. You can see it, Don at podiatrypracticemastery.com. I'll share kind of as I'm going through the struggle. Okay, but then the afternoon in my office was a good afternoon. I'll kind of go over this. Once again, one doctor, he asked for my treatment tracking sheet. I'd be happy to send that over. You just shoot me an email. Okay. So first patient in the afternoon was a 74-year-old female, had right hallux limitus. So I spent a lot of time talking about the spurring on the top. Hers wasn't that painful. She's really interested in going on this, 200-mile hike in Spain. And so she got orthotics, and I'm going to see her back in 8 weeks. So normally orthotics, they come back in about 2 to 3 weeks to pick them up, and then I see them about 6 weeks later. So usually they make a 2-month follow-up for them. Next was a 9-year-old little boy. He was here with his dad. He had bilateral severs, and he got. So this is funny. This is the benefit of my scribe. So as I was explaining this, I have a little treatment sheet. So once again, if you want my treatment sheets, just shoot me an email. I have a little treatment sheet that I go through, a little patient presentation, a little PowerPoint that I go through. And so he is going to do, the morning stretch, pretty much the same. Morning stretch, foam rolling, then you got a night splint. And he's going to do the Thule heel cushions, and he's going to start that. I'm going to see him back in about 4 weeks, and if it's not better, we'll either do shockwave or we're going to do orthotics. So I didn't tend to do those the first visit. We're going to do those the next visit based on his improvement. And the funny thing is, as I was leaving, Morali said to me, he said, Don, do you want to do one-sided night splint or bilateral? And I was just thinking about doing one. And when I asked the patient, or actually his father, do you want to do one of these or two of these? And the kid said, well, I want to do two. So you can do bilateral night splints, and I just find that a lot of times my scribe is more confident than I am. He just wants to clarify for his documentation, but it adds a lot of other things to me, because then I just ask the patient, hey, do you want to do one of these or two of these? In this case, since he had bilateral severs, he did bilateral night splints. So I'm going to see him back, and then we'll kind of go to the next step if needed. The next patient was a 72-year-old female. She had bilateral bunions. We did x-rays, and we did shoe recommendations. This was the husband and wife. So we did shoe recommendations for her. And she actually came from an ad in a local newspaper. So we do this weekly ad in a newspaper, and then once a year they do like a spotlight of the doctor. So they did a spotlight of me, and then she saw the ad, and she wanted to come in. And she had previously seen another podiatrist. She was there with her husband, who was about 10 years younger than her, and he was a 62-year-old man. He had a left peroneal, peroneus brevis tendonitis at the insertion. We did x-ray, we did ultrasound, and we did a cortisone in there. He came in expecting to do a cortisone, and I said, well, we'll do one cortisone. I'm going to see you back in 4 weeks. If it's not better, then we're going to do shockwave, and I kind of explained what shockwave was and the benefit. I think that would have been more beneficial for him, but he wanted to do the cortisone. He kind of came in with that expectation on his mind. He was already in a cam boot for 2 weeks before. Next was a 45-year-old female. She had EPAT number 1 out of 6 for plantar fasciitis. Next was a 38-year-old female. Did a left hallux avulsion, and she has been on 2 different types of antifungals. One was terbinafine, and now she is on diflucan. And she was having some swelling and pain at the nail base, and it wasn't getting better. And I think it was due to that kind of the nail that was there. So we did an avulsion today for her. She also is dealing with some chronic plantar fasciitis, and I find that certain patients, certain demographics, don't want to pay for treatment. They especially don't want to pay full price. So in these patients, what I tend to do is I don't push them. I just have them make that decision. And if they just kind of live in or sit in their pain, eventually they'll come through and want to do the shockwave. That's what she really needs, and she's going to set up those shockwaves. But I find it's not worth it for me to say, you need this, you need this, you need this. They really have to come to the point, well, their pain isn't going away and they want the shockwave. And she's already failed at 2 cortisone injections, and so I just said, this is the next thing that you need. So, and I leave it at that. In the past, I used to try to convince them, but I don't convince anymore. I just say, okay, who's next? You'll be back when you need it. Next patient was a 58-year-old female with a left fifth met. Can't read my so she has 2 things. She has a nerve in almost like a neuroma on the 5th met head. The way her foot is, she's walking on the nerve on the outside of the lateral side of the 5th metatarsal head. She has already had a couple of nerves removed on her second toe of both sides, and she kind of lands on the bone/nerve, and I can feel it click back and forth with my hand. So I've injected it twice. She has a wedding coming up for one of her sons, so I did a cortisone today. But we're going to come back, and I've done this one other time where I thought it was a soft tissue mass, actually, and I removed it. So I removed it right in the office. I make just a lengthwise incision where that nerve is, and I just remove that, just cut out that nerve in the office. The next was this was kind of my favorite, my MVP patient of the day. She had a 57-year-old female. She was seen by an orthopedist for an Achilles rupture, and he did an FDL transfer with this, and he did a bone anchor into the heel, and she is 7 months out. She's gone to PT, and she never even saw the surgeon for the post-op, just saw the PAs in this big hospital system we have here. And she came in. I know her from like my kids' sports, and I've been seeing her limp around. So she came in, and she has just a lot of thickness in her Achilles tendon, certainly after the rupture, a lot of effusion in there, some bone pieces and things like that. And she's going to be a prime candidate for shockwave. So we did shockwave number 1 out of 6 for her, and she just wants to get back to a little bit more normalcy in her life, and she's still kind of limping around. I told her she's still going to have tightness back there, and she's been doing the Graston technique and physical therapy, but I think the shockwave is really going to help her. We did x-rays. We also did ultrasound for her as well. Next was a patient with bilateral okay, this is kind of a lot of things this patient had. So these are these ones that they just add up and up and up in terms of the office visit. So first of all, she had the office visit, new patient, 77-year-old female, bilateral 5th met IPKs. So I treat those. They possibly could be warts, and so I treat those with lesion destruction. And in my documentation, I put in wart and I put in, IPK. She also had nails that she wanted done, and she wants to come back to see Marjorie, my nail tech. And then she also has right plantar fasciitis. So we did the x-rays, we did the Pelto special, which is the night splint, the foam rolling, and the morning stretch, along with the icing and the anti-inflammatories. I'm going to see her back in 3 weeks and see how she's doing. And then finally, we had a patient, that 37-year-old, for a right hallux IND. So we did that. That was the day. So it was kind of a busy afternoon after my surgery, but my big accomplishment was making that Facebook ad, which was very, very uncomfortable. I would love to know if anyone is really great at ads and how they're working for you. I know there are certain people that have courses and things like that. I really just tried to muscle through it my first time. I just kind of have to figure out. I know I could pay others, and I have paid others to do them in the past, but I kind of want to figure it out. So and then maybe once I understand a little bit, I don't mind paying someone to do it, but right now I just want to kind of figure it out. Okay, well, we'll talk to you guys tomorrow.